Hello, my name is Whitney Blankenship. I attend Gannon University's campus in Ruskin, Florida, and am pursuing my occupational therapy doctorate degree. Over the past year, I have conducted a systematic review with two of my professors in order to add relevant information for the field of health sciences, and more specifically, occupational therapy. This presentation will break the poster you see here into pieces to ensure readability. The topic of my poster is medication adherence assessments for children and adolescents ages 7 through 18. Before I begin, I want to give you a little background into why I decided to pursue this topic. I started my educational career focused on being a teacher and working with children with special needs, whether physical, cognitive, mental, or emotional. After getting more hands-on experience in the classroom, I realized my passion was to help people be as independent as possible through creativity and evidence-based practices within occupational therapy. Many of the kids that I worked with during and after I graduated from Grove City College were on a multitude of medications. Some of those kids were responsible for taking or administering their medications in certain doses and at specific times. I saw firsthand what the repercussions were when a child did not take his or her medications properly. They may fall asleep in class, be under-emotional or over-emotional, or symptoms would be exacerbated. Medication is an area under self-care within the Occupational Therapy Practice Framework, or OTPF, and is an activity of daily living for more kids than you may think. As I dug into the research, I came to find out that the average age of independence in medication management is 12 years old. Does that seem young to you? Do you think that a 12-year-old would have perfect adherence amidst their school, social life, while they're not at the home? Those questions got me wondering, what are the most effective and appropriate medication adherence assessments for this population? How are health professionals making sure a child is taking their medication the correct way, if at all? This population is clearly at risk for non-adherent behaviors, which could mean taking too much or not enough, whether it's intentional or not. It may be because they don't understand its purpose, or they may just forget. There has not been a systematic review in the literature that has synthesized the assessment tools that could evaluate this. Most research on this topic has to do with older adults with dementia. Before we get into how the study was conducted, I want to point your attention to the quotes about adherence and non-adherence. Adherence is the extent to which the patient follows medical instructions, and non-adherence is the best documented but least understood health-related behavior. Non-adherence and non-compliance were two of my key words when searching through the literature. My professors and I searched through CINAHL, Cochrane Library, Medline, PubMed, and PsycNet. All diagnoses and clinical settings were included, and the study had to be published after January 1st, 2005 to ensure its relevancy. In order to assess the assessment tools found in the studies, the CanChild Outcome Measures rating form was used. It looks at each assessment's focus, methodology, clinical utility, reliability, and validity. I chose this tool because it used elements of the International Classification of Functioning, Disability, and Health, or the ICF, which was published by the World Health Organization and is used frequently in the healthcare field. In this first table, the assessments can be seen on the left-hand column and include biological indicators, medication adherence questionnaire, electronic monitoring, pill counts, medication diaries, questionnaires for patients and for caregivers, and physician estimation of adherence. The attributes follow to the right, then perspective, or who the assessment is completed on, and then evaluation context. So to compare biological indicators, which could be a blood test or a urine test, we can see they can assess the body structures and functions. They are taken directly from the patient, and could be completed in any of these settings depending on the type. And an example of this would be testing a child's blood sugar if they are diabetic. Now, when comparing this to a medication diary, we are really only looking at the patient participation and activities and can't physically measure how much adherence the child actually has. This table shows the variety of formats, examiner qualifications, level of measurement, whether the manual of the tool is available and helpful, and if norms exist. So to keep our previous example, the biological indicators show to be physically invasive because they have to use part of the body to find their results. They require training to administer, but they give numeric data. They have specific instructions, and we know what the norm levels are for a typical blood test or a urine test. Compared to the diary, which is simply a piece of paper that requires the patient to write when they take their meds and how much. It requires no qualifications apart from just telling the patient what the instructions are and what to write. It has no formal manual, and there are no norms because it's subjective information. As you can see, these tables are helpful in the comparison of multiple tools and will lead us into author recommendations in the coming slides. The results of our searches reached 16 studies, and diagnoses included HIV, diabetes, asthma, cancer, inflammatory bowel disease, Crohn's disease, anemia, and depression. There was a total of 735 individuals used when combining all 16 studies. The types of studies included randomized control trials, cohort studies, cross-sectional studies, and case studies. Starting from the top of the chart previously, I'm going to talk through the major points of each assessment tool for the sake of time, but if you would like more information regarding one, feel free to contact me. My information will be at the end. As we've talked about, biological indicators are highly accurate, but they are invasive, they may not pick up on drug metabolism, interaction with other drugs, and white coat adherence, which is when a patient takes their medication only when they know they are going to be going to the doctor soon. This assessment tool is not possible for all diagnoses. Pill counts are low in cost because it follows a formula which can be seen on the screen. It's a time-consuming process, and there is no way to ensure if a pill that's missing from the bottle was actually ingested or ingested at the right time. Electronic monitoring is pictured here and is a pill bottle that records the date and time of each bottle opening. It's an unobtrusive method, and the patient simply stores their medication in the container. It can then be plugged into a computer to analyze the data it has taken to find patterns behind non-adherence. Does the child miss all of their medications in the morning? Do they miss them at lunch? It does not have a queuing mechanism to remind the child to take their medication, so its accuracy in predicting the actual adherence is higher. Unfortunately, it's a more expensive option, and it's similar to pill counts in the sense that ingestion is not insured. This concludes the objective methods, and now we're going to look at the subjective methods. Questionnaires are a low or no-cost option that could have standardized questions or more open-ended questions. The medication adherence measure is an example of a more standardized approach to the subjective tool due to its organization. Patients and caregivers may both take questionnaires, but bias may be present, and reports of adherence are higher than actual adherence when it is compared to biological indicators or electronic monitoring. As we've talked about, medication diaries rely on the patient to stay on track with writing down the patterns of their medication each day. There's no standard form, tools, or manual for this approach, and overestimation on adherence is common. One study analyzing patients with depression showed an overestimation of 6.5%, which could affect the symptoms they are experiencing and disrupt the effects of the medication. Physician estimated adherence is the last tool and is based on the opinion of the physician. They report based on the signs and symptoms they see by using this 100-millimeter line to report adherence. This tool has shown an overestimation of about 16.7%. The study's suggested tool is clearly electronic monitoring, but a secondary recommendation is that multiple sources be used, and more research needs to be done in this area. As with any evaluation tool and intervention, there is no gold standard because each patient is different. But it is important to note that subjective measures have higher rates of overestimation of adherence than the objective methods. Although questionnaires and diaries may flag a health provider for an at-risk child for non-adherence. The goal with assessing adherence is to identify the problem and mitigate treatment failure, rehospitalization, and relapse. Within this systematic review, many of the studies had weak outcome measure descriptions and small sample sizes. Like I mentioned earlier, a child is more likely to take their medications the right way when they have a new medication or when they know they are going to the doctor soon. It is also important to consider that some of the studies were short in length and may not show long-term adherence. So in conclusion, medication adherence assessments provide important insights into client behavior and patterns. Assessing adherence could be the difference in effectiveness of treatment or the exacerbation of symptoms. I hope this was educational and helpful for any health professionals attending this poster session. If you have any questions, please feel free to contact me. Thank you so much.